morning, every audience. This is a second case from Nanjing First Hospital, and I'm Dr. Fei Ye from Nanjing First Hospital. Today's moderator, no, today's operator is Dr. You Ge from Nanjing First Hospital. So I will introduce Dr. You to introduce her team.
Okay, thank you, Chief. Good morning. It's our great honor to show you this lab case. First, I'd like to invite our today's team. On my right hand, my two mates, Dr. Wu Xiangqi and Dr. Gan Jinxiang. We also have the IVUS interpreter. You're very familiar. It's also the head of our technicians, Dr. Pantol, and also Dr. Li Kai, Nurse Li Kai and Nurse Yan will also assist for us. Next, I'd like to invite Dr. Xiangqi to give you a case introduction for this patient. Doctor, please.
Good morning, honorable expert. It's my pleasure to show the patient's information. Patient, 83 years old, mate, recurrent chest tightness and shoulder brightness for 2 months. Risk factor essential hypertension, chronic kidney disease. Left test result showed low eGFR, high BNP. ECG showed atrial fibrillation, ST depression in left V2 defined. UCG shows moderate tricuspid regurgitation and low ejection fraction value. We diagnose the patient is coronary artery disease, heart failure, atrial fibrillation, essential hypertension, chronic kidney disease. Next. The patient did a CAG half years old. We see the LAO, the cranial position shows the proximal and the middle segment of RCA is a serious nasal lesion, accompanied with a serious calcified lesion. Next. We show the caudal and cranial position shows the LCS is total occlusion. And the proximal and the middle segment of LED is a serious nasal lesion accompanied with a severe to moderate calcified lesion. And the first diagnosis also is a serious nasal lesion. Next. The operator chose down the LCA CTO used DCB. The size is the 2.25 and the length is 30 millimeters because the LCS size is small. Next. Also, we calculate the syntest score 2 to evaluate the risk stratification. We find that the syntest score is very high, and the cabbage is suitable for this patient. However, the patient's age is very high, and he is reluctant to accept the cabbage. Thus, the PCI is our choice. Next. This time, the patient has symptoms. So what is our strategy? Cardiovascular, RCA, and LED, LB support, imaging guide PCI errors, or OCT, rotarotomy, or the combination with intravascular liposol. That's all. Thank you for attention.
Okay, thank you, Dr. Wu. Very clear case introduction. I think you will show you our today's corneal angiography. Okay, just give us the first picture. Just concern the patient's the very complex conferences. The patient is 83 years old with the very bad cardiac function and also has the renal function efficient. So we just used the very several pictures to show the patient's today's coronary anatomy. It's the cranial visual very clearly. The also very diffused lung lesion, just extend from the proximal LAD and extend to the distal LAD with the big angulation, and you can see from just from the angio very severe calcified. And unfortunately, we find the previously PCI vessel, the circumflex, re-occluded again. But fortunately, it's not the dominant vessel. And ICA, you can see very clearly from the LAO cranial and the LAO view and the LAO cranial view. and also the very diffuse lung lesion from the proximal ICA to the middle ICA, and also with the heavy certified view from the angiography. And this patient, as you know, with the very high syntax score, is the high risk level patient, and the lesion, also the trapped vessel disease, very complex. So definitely is the chief case. So just like Dr. Wu have told us how to perform the PCI for today's case, because the patient has no chance for the CABG, and the patient family strongly refused the CABG, the open chest surgery. So PCI is our only choice, LAD or the ICA, because I think the circumflex there is useless for this patient, even we recanalize again the circumflex. Because the patient's the bad condition, we just concerned with our team and with our chief. I think ICA is right dominant. First, PCI ICA will be safe and efficient, which will give the good support for the next PCI for the LAD. If today we just want to perform the LAD PCI, so we may need the mechanical circumambulatory device assistant like impeller and or the ECMO. Although we don't have the impeller in Chinese market, we have the ECMO here, but the patients has the multi-organ disease. I don't think ECMO is our initial choice. So today, our PCI strategy, we just want to PCI the ICA. And ICA, we just use the IABP standby. I think that's enough. Before that, please show me the LAO cranial view, please. We just use the transradial approach and use the 7 French guiding catheter is the SAL 0.75, and it runs through wire. And the wire, next please. Next please. Wire easily, next please. The wire very easily go to the distal ICA, but you can see the IVUS. Why we choose IVUS? Absolutely, the patient has the renal function, not good renal function, and not good cardiac function. So OCT is not our preferable. IVUS, I think, is probable for this case. You can see IVUS catheter cannot pass through. So chief, next, we decide to perform the rotational atherectomy for this case. That's what we want to do next. And Dr. Panton, will you show the first IVUS image to us?
Okay. Let me show the IVUS imaging. The first one we check IVUS from the proximal RCA to ostium RCA, but the calcium lumen is very small, so the IVUS cannot do the distal RCA. So we check IVUS from the proximal. And here we can see the proximal vessel diameter is about 3.5 millimeter. And here the calcification angle is about more than 300 degrees. So go on, pull back. We can see the calcification angle is about 180 degrees. So go on, pull back. This is the proximal RCA. This is the lift plug. And then go on here, near the guiding, we can see the vessel diameter is just 2.7 millimeter. Then go on, pull back, the vessel is about 3.5. Okay, this is the baseline IVUS imaging.
Okay, Chief. So we just from the IVUS measurement, the IVUS derived the calcium score, I think, at least nearly 2, which include the more than circumferential superficial calcified, nearly 336 degrees, and also have the main vessel diameter less than 3.5 millimeters. So we just accumulate the total score at least 2. So Chief, next I just like to choose the rotational atherectomy for the patient.
So based on the IVUS and angio result, even though you cannot push the IVUS catheter distally, why you choose the rota first, or why you cannot use the balloon, small balloon to predilate? Some experts like to use a 2O balloon to predilate with a mid or lower pressure. if there is found the balloon full expansion, we can check the IVUS again to show IVUS rota or not. The second question is which kind of the initial burr you will use? I mean the initial burr size.
The first initial burr I like to use the 1.5 because data from the Japanese also is just the observational study, and the results showed when compared with the 2.5 burr or the 1.5 burr, 1.25 burr has the similar. There's no difference between the complications between the two groups.
Step by steps with means size of the burr increase. There is a lower ratio of the slow flow or low flow. For this case, could you show the angle? Could you show the angle? You can select the rota first with the 1.5 burr.
Okay.
Okay, you also can use a tool balloon to pre-dial. It depends on your decision. Okay, so before rota, you will check the ACT routinely or not?
We have checked the ACT. ACT 320
Okay,
settings. Yeah.
okay. So you can go ahead. Go ahead in the rota.
Okay.
This is a 1.5 burr. What's the initial speed of the burr? Of the rota?
Chief, I like to start with the
1.5.
160.
160?
Yeah, high speed platform.
Okay.
So I will deliver the burr 1.5. Okay. Low speed mode.
It's low speed. Low speed.
Okay, go.
Yes. The before rota we also can
60,000.
no stop.
Okay.
Use the RL angel, RCA angel.
Please give us the
Yes, zoom.
the first angel.
Frozen there. RL, RCA angel, RCA angel. Zoom there. No. Frozen.
previously.
Yes.
This one. Okay, this one.
Okay.
Reference.
No. Not
Give
better.
us a
Yeah.
clear view.
It's
Clearly.
better.
Yeah.
Okay.
You may make sure the rota distance from here or to there. Yes.
Yes. Well, so we will start. Is the high speed as you mode?
Yes.
Yeah, it's
Okay.
high speed.
Yes.
Okay, we'll perform the first rota.
140, 50,000. More. 170, 170,000. Okay.
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 Just encounter very strong resistance.
So during the rota procedure, we should pay attention to the heart rate and the blood pressure.
Yeah, blood pressure is okay. No EKG changes since now. We have the 30 seconds interval, Chief.
So we'll pay attention to the patient's symptom. Yes, after the while, the distal while. Okay,
30 seconds is over.
Okay.
Okay. I'll perform the second round.
Yes.
170,000. 5 seconds. 10 seconds. 14 seconds.
14. Move the rota procedure. Move it. Move it.
Record.
No. Move the rota burr. Move the rota burr.
记录.
No. Stop here. That's enough.
So Chief, if there is also no, I mean the movement for the 1.5, I'd like to de-escalation, maybe
Yes,
choose a small size burr.
Yes, we can see the speed down very sharp. Less than 5,000, we can push the burr little distally. If still over 5,000, okay, we can move the same place.
Okay, so the third round.
Yes.
Yes, third
Ready?
one.
Okay.
170,000. 10 seconds.
Okay, I can see a bit movement of the burr.
Record it.
Yeah.
Okay, move it. Move the bar. Yes. No, no, enough. No, no, move it. Push. No. Yes, here is enough. We can see the resistance. We just add the second part of the RCA.
Yeah.
Okay. How about the speed down?
10,000.
Okay. We should push the rotor for the same place for the second times, third times.
Okay, low speed. I will.
Low
stand by.
speed.
Okay. I will send a little bit the burr. Okay.
Push the wire distally.
Okay.
High speed.
High speed. Okay, ready?
Okay.
Ready.
Okay. The fourth round.
160,000. 5 seconds. 10 seconds.
Okay. Very strong resistance.
Record it.
That's
Yes, move it.
7,000.
Move the picture. So still the same place.
Yeah, the
You
same
cannot
place.
push the rotor bar distally.
Yeah.
Okay, maybe after several times we can increase the rotor speed.
Rotor or increase the rotor speed.
Yes,
Dr. Pan, please.
just for the second. Okay, try again.
Try again.
If still failed, okay, we can increase the rotor speed.
Okay.
Low speed.
Low speed. Okay. I will send a little bit the burr.
Okay.
The high speed mode. Okay.
High speed.
Okay. Increase the speed.
Okay.
Okay.
160,000.
Enough.
5 seconds. 10 seconds.
Okay. I can see some movement. Yeah. We
15,000.
just yeah can see the advancement of the burr.
16.
15.
No, increase the speed.
So Chief, you can see a bit movement.
Yes, we can see the rotor bar move a little distally.
Yeah.
Yes, we can see it. Just because severe calcification maybe over 270 degree, just because calcification was very diffuse. So we can we can perform the rotor for several times. Still pay attention to the heart pressure. No, the patient's heart rate and the blood pressure. The heart rate and blood pressure was very stable. Okay, we can rotor for several times.
Okay.
Just because before the procedure we check the SCT over 300. That's enough safety for the rotor procedure.
Okay. So Dr. Pan, you ready?
Ready?
Okay. The sixth round. Okay.
160,000. 5 seconds.
Okay. We
10
just
seconds.
pass through. Okay.
Yes,
That's 5,000.
put it back. Check the angle. Just because there is phenomena.
Yeah, heartbeats.
Yes,
slow.
push a little.
I will retrieve the getting calcium.
Yes,
Just
okay.
engage
Check
too much.
check
Okay.
the angle. Check the angle.
Okay. Okay, flow is good.
Okay,
Chief.
okay.
Yeah.
No problem. If we find the burr push very quickly.
Chief, the final round I just learned to use the low speed to polish the. Okay.
No problem.
待会要降点速度啊，抛光。
150,000.
Okay. So till now the patient's hemodynamic stable. You ready?
Okay, yeah.
I'm ready.
Okay, maybe the final round. Okay.
Okay. 150,000.
So there's no resistance and there's no speed deceleration, right?
10
Yes.
seconds.
Okay.
We should make sure there's the speed low, the speed down less than 5,000.
Yeah,
Okay.
5,000.
So we can finish the first whole procedure
No
of the
sleep.
ROTA with a 1.5 bar. Then we check the IVUS.
Okay, prepare the run-through wire for me. I will check the IVUS.
Okay.
Run-through wire.
Run-through where? Run-through. Run-through.
Finish on. Run-through wire, please. Run-through wire, please. IVUS, prepare the IVUS.
Yeah.
Recheck the
Everything
IVUS.
ready.
Okay. So Chief, just because the patient has the poor renal function, I just want to use the lower contrast volume. Okay. Okay, IVUS. Give him nitro.
NTG.
Give 200 nitro. IVUS is okay, Dr. Pan?
Okay.
Okay.
So I think IVUS is very, very important for we to discuss to perform another ROTA or not. If we find the crack of the calcification or we find the
Yeah, okay, Chief.
yes,
You see
okay,
very smoothly to deliver the IVUS catheter.
Okay.
yes, we
Please
can
go.
see.
Yeah.
I will pull back. The distal RCA is normal.
Very,
Yes, I
very
think
huge
yes,
vessel.
Yeah.
the vessel is a lot small.
Vessel
and,
diameter is more than 3.5.
yes,
2.5, okay. The big vessel.
And here we can see eccentric plaque,
Okay.
calcified plaque. But here the calcification angle is not more than 180 degrees.
yeah,
Here the lumen is very small.
Reference diameter more than 3, right? 3.5.
Yeah, 3.5. Here you can find the 40 calcium.
Okay, here comes the calcified.
Yeah. Calcification angle is about 180 degrees.
180, okay.
Maybe the lumen diameter about 2.0.
Okay. It seems like we have the reverberation, right?
This
ah,
this
Here,
angle is about 360
Nearly.
degrees.
okay. The length less than 5 millimeters.
Yeah.
Okay, here.
Yeah, here you can see crack. Yeah.
You can
Maybe
see. You can see the crack.
Yeah, you can see the crack. So I think we use NC balloon. It's okay.
See balloon.
This is a proximal RCA.
I see. Nearly 4, right? Reference diameter nearly 4.
Yeah, diameter more than 4. It's a lipid plaque. Proximal RCA is normal.
Okay,
Stop.
we'll stop. So, Doctor, please just measure. We just want to see the heavily calcified site. Oh, for the proximal. Okay, here.
Yeah, this is the calcium.
But not continuous, right? You can see the crack here.
Yeah, I can see the crack.
Oh, here more than 270 degrees.
Yeah.
Okay, and the reverberation. So it just indicates the calcified plaque, the density is higher, right? The C calcified plaque. So Chief, just from the IVUS-Guided, I'd like to use the lithotripsy. I think IVL should be probable because the the minimal lumen diameter nearly more than 2, right? Dr. Pan, 最小管腔直径给好点 nearly 2，管腔直径也量一下
Okay.
，OK， or nearly 1.8.
Yeah.
If we want to escalation bus size, maybe we need to use the 2 balloon, 2 millimeter burr, right?
Yeah.
But here, just concern the patient's not good cardiac function. I think lithotripsy will be very suitable for the case. How about this, Chief?
You can use anything, but
Yeah. Look here, Dr. Pan, just a measurement for us. If we use the IVL, the lithotripsy, how about the balloon size is suitable? 3.0 or 3.5?
3.5.
3.5 is better.
Yeah, 3.5 is
Okay.
better.
so
The
could
Chief.
you enjoy it?
Okay, I'll
Give
take
me
it.
angio. So I don't know why you choose IVL first. Why you cannot use another NC balloon to predilate? Just because this is diffuse calcified lesion, you will use IVL. Which side and which part you will use IVL first? Just because only 80 times for use for one balloon. So predilate. If we find there is an expansion, use IVL there.
Okay.
If we find a lot of diffuse lesion, calcified lesion, how many IVL balloons we will use?
Okay, agree. Okay, Chief. We follow you.
So you can use the 3.0 balloon,
3.0
NC balloon, or cutting balloon.
3.0
First,
balloon.
you will find the under expansion. Where is the under expansion? Okay, use the IVL there.
Okay.
Okay.
You will find so.
We prepared the NC balloon predilation.
Okay,
first.
present the final. Yes. This is not a focal calcified lesion. Okay, where will you will use
3.0 balloon. Okay.
NC? Just NC is okay. NC is okay. Sometimes we want to use a cutting balloon.
This
Cutting
is
is
cutting
better.
balloon. This is the cutting balloon.
What's the size of the cutting? 3.0. Okay, you can use a cutting balloon. I think maybe cutting balloon cannot push it distally.
Agree with you. I will try.
What's the guiding caster?
It's the San French cell.
Cell
Yeah, right.
0.75
Yeah.
or 1.0.
Yeah. Just like you.
No, cutting balloon is not easier to push distally. Okay.
I will change for the NC balloon.
Okay, NC
NC
balloon.
is better.
NC balloon.
Well, so Dr. Pan, could you tell me where's the severe calcification location? I mean the position. 钙化最重的地方在哪儿
It's here. This
The
point.
length of the severe calcification to the osteo RCA.
Okay, please inflate.
到开口的距离多长
Okay, 12,
12,
16.
16, 16.
Okay, done.
Okay.
Yeah, seems it works, Chief. This is a
22.
3.0 NC balloon.
22.
Yeah.
Yeah.
Okay.
12.
12. 16. 16.
16.
16. Okay, done.
Okay.
Yeah, it works. Go.
12.
16.
15.
Okay, done. Go.
12.
16.
15.
Okay, seems okay.
Okay.
Done. Okay, once more.
12, 15.
16.
Okay.
Okay, done. So Chief, the 3.0 works very well. And just because the reference diameter here more than 3.5, I like to use the
Now
7
check
parts.
the IVUS. We
Check the
will
IVUS,
see
okay.
there is crack of the calcification.
Okay,
Okay.
IVUS again.
NTG.
Even though just because IVUS cannot tell us the calcification is thickness, we don't know which is better, NC balloon or IVL. If we check with the OCT, we can see there is a thick calcification. So we can know where we should use the IVL.
Yeah, I agree with you, Chief. If the patient has a good renal function, I would choose the OCT
No,
first.
IVUS is enough for this
Cool.
case with the NC balloon to check. Yes.
Logo.
Yeah. This one we check out from distal RCA to proximal RCA. Distal vessel is normal. Vessel diameter is also 3.5.
3.5,
Yeah.
okay.
Here is calcified plaque. Here we can see medial dissection. The medial dissection is very long.
Here comes the calcified plaque.
Yeah. You can see the crack. One crack.
Yeah, very clear.
We should pay attention to the ring shape calcification.
Here is medial dissection. This is a crack.
Yeah.
Yeah. And the lumen diameter is more than 2.0.
Uncontinuous, right? You can
Yeah,
see
very crack.
yeah, several cracks.
So I think
Here comes to
after
the
pre-dilation is okay.
here's come to this is the proximal segment, right?
Yeah. So I will stop.
Yeah, you can stop. You can stop.
Okay.
Please measure for us.
And the neediness from the distal landing rule to proximal landing rule is 60 millimeter.
Okay. And how about lesion length from the distal landing zone to the proximal?
Yeah.
Okay. Yeah. Right. Okay. That's good. Okay. 3.5. Right.
Yeah. 3.5.
Okay. Lesion length. Oh, nearly 60. Right. Okay.
Yeah,
Two stands.
yeah.
To longer stand. Okay.
Yeah.
So Chief, I think the preparation is very is enough. I like to deploy the stand 3.5 for the first one. 3.5最长的。Yeah, okay.
So what's the brand?
3.5. 33.
33,
Okay.
yeah.
Okay.
The Chief is the Chinese domestic DES from the microport manufacturer. Okay. Very smooth. Okay, just a test, please. Test, please. Okay, good. Yeah, go. Just go. Go. No, not picture. Go. We just to can choose the
8.
contrast volume. Okay.
8.
Done. Done. Once more, going up to 12. 12. Okay, done. Yeah, nominal pressure to deploy the stand. I will delete the overlap side. Okay, go. Going up to 12.
12.
Yeah, 12.
Okay.
Okay, seems good. Expand very well. Yeah, right. No, I don't need tests.
Okay.
Okay, give me another. Maybe give me 4. How about Dr. Pan? Proximal segment 4. Do you think
Yeah,
it's
4,
okay?
4.
Okay, 4. Yeah, the same length.
So check the first run of the proximate RCA or second run.
The second run
proximal.
is proximal.
Okay.
So I
So
think.
the landing zoom of the proximal part of.
So I think the 3.5 is better.
So if I use the 4.0 along stand, I just use the low pressure to deploy.
So the landing zoom of the proximal part of the RCA is what's the length of the proximal landing zoom to the osteo RCA? Proximal landing zoom. 就你给往开口多远
just maybe 5 millimeter.
Okay.
5 millimeter. The chief, I will just use low pressure to deploy the 4.0 stand, just to avoid the complication of the standing. Please prepare the 3.5 and the 4.0 NC balloon. Okay. No. No contrast. Okay. Yeah. Test, please. Okay. Test, please. Yeah. Proximal. Okay. Go.
12.
Yeah. Going up to 10. 10 enough. 10 enough.
10. Okay. 10.
Okay. Done. Okay. Done.
Okay.
Yeah. Here. Going back to 10.
10.
20.
20.
Okay. Done. Okay. Give me the 3.5 NC balloon. So I will give the picture just after standing. Okay, seems good. But we still need the post dilation for the standard segment. It's the 3.5?
3.5? Yeah, 3.5. And
Quinton. Okay. So till now, we only use the less than 50 milliliter contrast, right? 上一季我们用了多少了？现在 Okay, please go. 12.
How about the EGFR of this patient?
It's only 30.
30.
Yeah. 12.
Okay.
14.
14.
Okay, enough. Done.
It's Paris 3. It's PD.
EGFR was very low.
Yeah.
Okay,
It's a grade 5 renal or chronic renal disease.
Yeah, 16.
So,
Okay. 16.
so there is a question to ask you for this particular case. How would you decide between IVL or ROTA or both?
16.
Okay, done. Okay, Chief. Just I want to, for this case, I just want to quick. It's after all, it's the chip case, and you can see the previously circ
16.
recluded again. This is
16.
why I just want to use the small volume contrast done to finish today's case. next time I think I will use maybe the IBP standby to treat the LAD disease.
No.
But
14.
after rotor 1.5 rotor, you know, the IVL used to be my first choice, but I think you have a lot of experience.
Okay.
I just wanted to quick defend the case. So you just asked me to advise me to use the NC balloon. I think it's also a very good choice. Done. Go.
14.
So IVL is for. So the particular case is an indication of IVL. The question is to ask you the indication of the IVL, indication of the rota, indication of the both. Not for I want to use.
Yeah, I think so.
Not for your experience. So is any indication?
If the NC balloon also have the from the IVUS, I just also according to the IVUS derived the calcium score more than 2, and for the very big vessel, and the big size, big bird size is not suitable. I think IVL.
So you know, before the paper of the IVUS score for the calcification lesion, there is low IVL data. So we don't know. IVUS score is not suitable for IVL. CVI means of OCT score for calcification is not also indicating for the IVL. Maybe it's just the indication for the rota. So the IVL is better for the calcification. The question is the thickness of the calcification. Is any IVL used for very thick calcification? The question is first, what should we do for the first choice? Second, the first is to short, modifier, or debulking. The second is NC balloon or high pressure balloon available for the calcification after rota, just because we can perform modification or debulking.
NTG supplement.
Yeah, Chief. So before we have the lithotripsy, the only choice we have for the severe calcified, especially for the big vessels, the reference time more than 3.0, and the bigger size burr, the preparation, I think is the only one, the only choice.
Yes, we think IVL is suitable for a very focal calcification. For diffuse calcification, what should we do? We can make a lot of IVL balloon. We can use, but the rota is the best first choice. So the second is to after rota is 1.5 burr enough? We don't know. Yeah. We should make use of debulking or modification for the calcification. So the question is, make the thickness of the calcification thinner or thinner? It's better for we to crack the calcification. So the most important issue to crack the calcification, if we cannot use a rota or NC balloon, it doesn't work. Okay, we can use IVL.
You think if the big size burr works, we don't need to use the IVL?
We don't use IVL routinely for the calcification.
Also,
it has some indication.
Yeah, although we don't have the ICT evidence, the only reference that we can use is the disrupt study. But
only for here now we can use before standing. We can make sure the crack of the calcification. This is very important. We don't need to use IVL. The crack is the most important issue. The second is we cannot make the crack. Okay, we can use IVL. So multiple crack is better than the single crack.
Yeah.
So that's all. We don't know IVL is routinely for used for calcification is better than the no use. We don't know. So crack is most important. The second is post-standing. Minimal luminal area is the best factors of predicting the clinical outcome.
I agree with you.
So we can measure the stent expansion. We can make sure there is low metal position of the stent structure. That's very, very important. If there is still under expansion of the stent, okay, we can bear out to use IVR. For my experience, there is no evidence. So I think stent expansion is very important. How to make the stent expansion well?
The more cracks we have, we will have
multiple crack of the
yeah.
calcification. Yes.
Yeah.
How to make the multiple crack? If rota, if NC balloon, if scoring balloon doesn't work, okay, we can use IVR. If we use OCT to measure the thickness of the calcification, we can predict there is NC balloon can work for this kind of calcification. If the thickness is over 0.9 millimeter, okay, we cannot use NC balloon or cutting balloon to crack the calcification.
So
what should we do?
We should debugging first.
Yes, we should use the rotor first to
yeah.
make the thick of the calcification thinner. First. Second, if we use the largest burr in our cast lab, even though 2.0 burr in our cast lab still doesn't work, okay, we can use a cutting balloon. We can use the IVR. If we can use the NC balloon to crack the calcification, why we should use the IVR?
Yeah.
So we can measure the final result of the stent.
Yeah. I will check the minimal stent area. You can find this point is the minimal stent area. The area is about 6.2 millimeter square.
6.2.
Yeah. And the key, we can see the distal stent edge is normal, no plaque burden. And the proximal stent is normal too. So the IVUS result is consistent ultimate trial.
On the expanding here.
Yeah.
So where? From the angle where?
Just in the heavy
the lens, the lens
calcified site.
Yeah, the proximal about 22
okay.
millimeter.
Okay, still high pressure balloon post dilation there.
Yeah.
Even there is still on the expansion, we can bear out use. Yes, maybe. That's a question. Even though we find the crack of the calcification standing okay, not. Multiple crack is better. Single crack is not better. From the IVUS detection before standing, we can find that there is only a single crack of the stent, or of the calcification.
Yes, still we can have the width.
So post dilation with high pressure.
Okay, give me 3.0. Oh no. 4 please. 4.0.
Yeah. It's
no. Could you tell me the proximate part of the?
I think 3.5.
3.5.
3.5. Okay, 3.5. 3.5.
Yes.
Yeah, 3.5.
So Chief, before standing, if I use the 3.5 cutting balloon, maybe we will have the better result.
That's why we want to combine the cutting balloon with the rotor. If we use the NC balloon to post pre-dilation after rotor, we cannot make multiple crack of the calcification. If we use a cutting balloon, we can make a lot of multiple crack of the calcification compared with NC balloon. That's why we want to always use the rotor combined with cutting.
22. Okay. Yeah. One more again. Yeah. 20. Okay, now it's the 3.5 NC balloon. Just inflate at the 22 atmosphere. Okay, done. Yeah. Okay. 20. Okay, 22.
20.
22. Okay, done.
Okay.
Done. So Dr. Bentall, we will check IVUS again.
Okay. IVUS is ready.
Okay, IVUS. IVUS is ready.
Ready.
Okay. This time I will not give you the whole segment, just the expansion segment. Okay, just here.
Okay,
Please.
I will
Yeah.
pull back.
Okay, please go.
This is a proximal LAD to
Yeah,
ostimal,
yeah.
or proximal RCA to a ostimal RCA.
Mm-hmm.
And here the stent diameter is more than 3.2.
3.2.
Yeah. Here it's just 3.0. Mean diameter is about
Seems like we don't have the small gap, right?
yeah, just 1 millimeter
Okay.
gap,
Two stents not overlap.
not overlap.
Okay.
This is a proximal stent. And here the mean diameter is not more than 3.
Statue.
Okay, I think we can finish.
Okay,
Please
I will
measure
stop.
the MSA again.
Okay, I will check it again.
Yeah.
I think maybe more than 7.
A little big.
Oh, it's about 6.5.
Okay.
So how about the reference area? Could you calculate the stand expansion?
Which reference? Here reference.
No, proximal. Or distal?
Proximal.
Yes, here is enough.
Proximal.
Stand area.
Maybe 3.
Stand area.
27.
Stand area. Area.
Oh, sorry.
Yes.
Area more than
11.
So
11.
so we think the expansion here is just about 60%. Is that right?
yeah 60%.
Okay, we can use IVR.
IVL.
You can change to the RAO cranial. RAO cranial.
Okay. So, Chief, if we choose the IVL, how about the size? At least the 3.5, right?
So you can measure the stand size.
Dr. Pan,
Even
please.
though
Here's the reference diameter.
yes.
3.5. Okay, here, just
Yeah.
here.
3.5.
But before
Is
that,
that
Chief,
a stand expansion or just there is a gap?
yeah, I think so. Chief, before that, I just want to add one stand. 3.5最短的 DES.
Okay.
Give me one.
No overlap of the two
Yeah.
stand.
Yeah.
Even though IVR used for post standing is not indicate for the IVR, there is no consensus or guideline for IVR post direct standing.
So, Chief, you mean the newly deployed stand or the old deployed stand?
Old stand is okay just because stand failure after for several times there is no polymer, no drug in the superficial of the stand. Okay, we can use IVR. If there is a polymer okay integrity on the stop here. So there is only just the newer stand we put into the vessel. We can we will destroy the polymer on the drug of the stand. There is no, so we don't know the future outcome after we use IVR for this kind of situation. Sometimes we use a postulation. This is MRA in stand.
Yeah.
Okay.
In
stand.
Okay.
Right.
In stand.
That's why if we use intravascular image guided PCI for calcification, we should make sure there is a multiple crack of calcification before standing. That's very, very important issue. Even though we find the only single single crack of the calcification. Even though we put a stent, we cannot get a very good stent expansion after post full PCI procedure.
8,
14.
40,
14.
40.
Okay. Okay, done.
This is a 4035 stent.
This is a 3.5 stand.
3.5
Yeah,
stand.
3.5 stand.
Okay, post dilation with 3.5 to a high pressure balloon.
36高球呢
Okay.
Please.
And if we still find that on the expansion, based on the ultimate criteria, we can use IVR
Okay.
belt. This is just experience, not guideline recommendation.
Please go 20. 20. 20. Okay, done. 20, please. 22. Okay, done. Okay, 22. Okay, done. Okay, IVUS. Please prepare the IVUS.
Okay, IVUS
Go.
is ready.
20. 20.
And
Yes,
the time we
IVUS.
just have 1 minute.
Okay, done.
Okay, IVUS.
Okay, before that, I'll give you a picture. Okay.
Okay, we can check the IVUS.
IVUS, please.
Sometimes we don't use intravascular image guided for the calcification. We make sure the 1-to-1 NC balloon predilate the lesion fully, which means predilation stand balloon
go.
for expansion before standing is very, very important. 1-to-1 is very, very important issue. We don't want to use a smaller balloon to predilate the lesion. After that, we put a larger stent. Sometimes we find after standing, we find the stent on the expansion, even though the bailout strategy was very, very limited.
So that's what you teach us always, that use the big size balloon to
Not
predilation to prepare.
just 1-to-1 NC balloon. 1-to-1 NC balloon. Even though we find the crack, multiple crack, or maybe a single cracked 1-to-1 NC balloon.
Okay.
Predilate. After that, we put the same size of the stent.
Okay.
Okay.
Thank you. Dr. Kran, please.
Okay, I will stop next week.